Good afternoon. Welcome to Medical Grand Rounds. As is appropriate when we're talking about computers, we're having a little bit of Zoom problem here, but hopefully it's been rectified, and we'll keep an eye on it and come back right away if for some reason we fall off. I'm Bob Wachter. I'm chair of the Department of Medicine at UCSF. I'm thrilled to host this session, which I think will be incredibly interesting, and obviously it's extraordinarily timely. The session will be on ChatGPT. Will it transform the world of healthcare? Clearly, computers have always raised amazing opportunities to expand the abilities of humans, but also at the same time, almost always present new and challenging questions and unanticipated consequences. And I can't think of anything that's done that more starkly in the last 20 years than the new large language model AI tools, most obviously ChatGPT, but apparently there are a whole bunch of others that are like it working. You may have seen the announcement by Microsoft yesterday or the day before about integrating this technology into Bing, their search engine, and the New York Times wrote a column saying that now is their preferred search engine over Google. So game changer in all sorts of ways. In today's session, we are going to discuss AI's current and potential uses in light of this new development in areas that range from clinical care to research to education. After a brief presentation by each of our four terrific speakers, I will moderate a panel discussion. And I don't know if Danielle is here, we can get the slides up. All right, so I just want to say a word for those of you that are new to Grand Rounds, a word about UCSF Medical Grand Rounds, a journey through cutting edge medical advances. In this weekly medical lecture series, we follow a talented cast of doctors, researchers, and specialists as they delve into the latest and greatest advances in the field of medicine. Audiences taken on a thrilling ride through complex medical concepts, case studies, and thought-provoking discussions. I'll skip the next paragraph because of time. So come along for the ride and discover the exciting world of medicine with UCSF Medicine Grand Rounds. It's a must-see for anyone looking to stay ahead of the curve in this constantly evolving field. I put this together in case any of you have not had a chance to play with ChatGPT. Next, please. So this is what ChatGPT gave me when I asked to describe UCSF Medical Grand Rounds in the style of a movie review. And just more and more examples that we're hearing of people using it in new and interesting ways. And it is a little bit magical. And so we will focus on the magic and focus on how it all works. But much of our time will be then drilling down to our world of healthcare, clinical, educational research, and see what the implications are. So for that, we have four extraordinary experts in the field who will cover different aspects of it. The first will be Aaron Einstein, who's associate professor in our division of endocrinology. He's also vice president of digital health at UCSF Health and senior director of the UCSF Center for Digital Health Innovation. After Aaron, we'll have Sarah Murray, who's associate professor of medicine in the division of hospital medicine at UCSF Health. She's also associate chief medical information officer and in charge of inpatient care and data science for UCSF Health. Next, Dan Lowenstein, who is a professor in the Department of Neurology. It's a little hard to say that, Dan, so I'll also say that he's former, as of a month or two ago, former executive vice chancellor and provost at UCSF. He'll focus mostly on the implications for education. And last, but very much not least, Atul Butte, who is the Chan Zuckerberg Distinguished Professor and director of the Baker Computational Health Sciences Institute at UCSF, as well as the chief data scientist for UC Health. So I hope you'll agree, it's hard to imagine a better qualified panel of folks to talk about the implications of this new and exciting technology for our world. So with that, I'm going to hand it off to Aaron.
Thanks, Bob. And these are my disclosures, mostly some advisory in the diabetes space, and you can click over to the next slide. So it'll come as no surprise to any of you listening that as you look around at other industries and compare where we are in healthcare and thinking about AI adoption, we are near the bottom in terms when we look at other industries and look at healthcare. So I want to talk really quickly about some of the reasons for why that is, some of the reasons we're a little bit behind, and shift into talking about GPT, and then I'll hand it over to Sarah. You can go to the next slide. So one of the problems and one of the reasons we are further behind in AI is I think in many cases we are choosing the wrong use cases. So we get easily seduced by the idea of solving really big, complicated healthcare problems using artificial intelligence, the things that vex us or that are very exciting, and we put a lot of research energy into that. And in fact, when you look at other industries, they start in more simple use cases. And so, sepsis being a great example of something you see all the time, these research articles about sepsis algorithms, and then they don't translate into practice. So if you click over to the next slide, the way that until GPT, the way that we thought things would progress with AI in healthcare is actually starting with routine repetitive tasks. So the things that humans don't like to do that take a lot of manual labor, prior authorization paperwork, things related to patient experience, web analytics, and understanding customer experience, imaging data, lots of early opportunity for using AI in those spaces. And over time, seeing the progression more into the clinical spaces, things like remote monitoring, and understanding care at home and patient-generated health data, and then eventually into precision medicine. And so I think mistake number one over the past several years has been trying to start on the right side of this and trying to start with these more complex use cases and not starting with the earlier, easier stuff that can solve some real pain points. Next slide. The second reason things have been slow to get off the ground, I think, is we often tend to overly focus on the algorithm. So one example, and Sarah's team at UCSF was really leading this work, so I'm going to share her story here, is when we thought about how to avoid the problem of patients, of getting more patients to their appointments, of avoiding no-shows, and making sure that we're using our clinic slots and that people are getting the care they need. There's one way of approaching it that says, well, let's build an algorithm to predict no-shows. The problem is that when you focused everything on the algorithm, you confuse that for what the outcome might be. And so we were often confusing the algorithm and what we want the outcome to be or the problem to be solved. And so if you click ahead, success really comes when you focus holistically on the problem you're trying to solve, the outcome you're trying to achieve. And so Sarah's team has been iterating with this and really thinking about which patients might benefit from a telehealth appointment, or which patients might benefit from getting a ride and transportation to clinic. And so by reframing the question and by designing the entire end-to-end solution, rather than by just thinking you can build an AI algorithm, kind of drop it in and see what happens, it really allows for better success towards achieving those outcomes. Next slide. And so McKinsey looked across, and this is industry-wide, they looked at high performers and other companies that were not performing as high in AI. And actually the number one predictor among many predictors was organizations that use design thinking when developing AI tools. So again, thinking about what outcome you're trying to achieve, what your user is trying to accomplish, and designing for that end-to-end workflow and process. And it's not just about the algorithm itself. You have a great algorithm, but not the outcome you want. Next slide. So of course we know, we've seen this image before of electronic health records and doctors having their backs to patients sitting in the room and not having face-to-face interactions and engagement with our patients. And so we know that over the last decade, that while technology has made many things in healthcare better, we haven't really solved all of our biggest challenges, and we haven't used machines to really augment the patient relationship. And so I think the exciting opportunity and the compelling opportunity here, if you click to the next slide, and I think Eric Topol captured this really well. Again, let's not think about replacing the things that we love doing as doctors, those patient interactions, our time spent talking with patients, and not thinking about AI to cure cancer, but using AI to solve the prior authorization paperwork, the things that take up a lot of time and energy and are not the things that we love doing as doctors and nurses and other clinicians, and restoring the human interaction between patients and doctors. Next slide. And this isn't just a fantasy. So I'm really lucky as an endocrinologist. I take care of many people who have type 1 diabetes and are using automated insulin delivery systems. And so that's a system where their glucose monitoring is connected to an algorithm, and the insulin pump is adjusting itself up and down. And what I found in my practice is that in the past, I was spending a lot of time poring over numbers, trying to understand patterns in people's glucose data and make adjustments to their insulin regimen. And now with people having automated insulin delivery, I had a patient come to me a couple of weeks ago and they said, we just spent 30 minutes and we didn't even talk about my insulin pump or my diabetes. And so it's been a wonderful opportunity to actually spend time engaging with my patients. And I feel like it's given me the opportunity to kind of peer into the future of what things might be like when AI is augmenting care and allowing us to get back to being healers and really engaging with our patients. Next slide. So along comes GPT. And again, what's the thing we love doing most as doctors? We love doing administrative paperwork, right? So of course not. That's not why we got into medical school and not why we got into this field. And so one enterprising doctor posted this TikTok video using ChatGPT to write a appeal letter to a insurance company trying to argue for an echocardiogram. So people are starting to get, as GPT has come along, people are starting to think about what are these use cases that are taking up a lot of my time and where basically an AI helper could help offload me and do something faster for me. So here's one exciting example, write that insurance appeal letter. Here's another one. If you click to the next slide and start this video. So I took a long chunk of information that I had about hypoglycemia and hyperglycemia. This is a couple of pages of information, very dense, very textbook-like. I asked ChatGPT to summarize it at a 6th grade reading level. And here's what it spits out. It spits out a very nice 1-paragraph summary. Well, maybe that's a little bit too simple. Let's do that at a 9th grade reading level. And it makes it a little bit more complex. So you can start to see the opportunity here to speed up tasks that we do that take up a lot of time and that can allow for a little bit more personalization and customization. It's not, I would still go in and edit this, but it's getting the work started for you. So you can go on to the next video. So last use case, and I'm going to turn it over to Sarah here. So imagine that you're sitting down to write a chart. This is actually a real case vignette from teaching our first-year medical students last week in their endocrinology block. You're sitting down, you've got your one-liner in the box there, and along comes the GPT model, and it gives you a differential diagnosis, tees up your diagnostic and treatment plan. Of course, again, the accuracy here is not perfect, and this would require a lot of editing. But you can think, if this is starting the work for you, you can think about all of the effort that it can potentially save in terms of getting things started. And you can imagine this sort of personalized scribe sitting on your shoulder, helping you do your documentation. So Sarah, over to you.
Thanks, Aaron. Go ahead, Sarah.
Great, thanks. So what is GPT-3? So it was created by a company in San Francisco called OpenAI, and it's an unsupervised deep learning model that was trained on a tremendous amount of text that was gathered from the internet up until 2021. It has 175 billion parameters, which is 10 times more than its predecessor. And if you haven't tried it, it's open to the public for conversational use via this tool ChatGPT, which really generates plausible text responses that can be quite long, as Aaron demonstrated, in response to worded prompts. Next slide. Okay, so taking a step back, Aaron and I really share a soapbox in terms of how we've approached traditional AI, which is that, before we do anything, we first, ensure we've identified the problem we're trying to solve. Then we consider whether AI is really the right solution for that problem. And then beyond that, we strive to understand and plan how we're going to use the AI to drive change, because that's really critical to the success of any implementation in healthcare. And only then, once we have all those pieces in place, do we actually start building the AI. Next. So what I think is interesting here is, tools like ChatGPT have presented a bit of a paradigm shift, because it's really, AI to the people. The tool is open and available to everyone. Anyone can test their own use cases. And we encourage you to do that, while understanding some of the limitations of these models. But I think from some of this experimentation that we're seeing, that Aaron's already shown, we're starting to see these new use cases bubble up. And from those, we'll be able to select the best ones, figure out what can be integrated into health systems, and then refine these large learning models to best meet our needs. Next. Okay, so what are the possible applications in healthcare? I'll say that none of these are totally ready for prime time, but this is where I think we're going. For clinical documentation, I'm going to briefly discuss an example of a tool we're looking at UCSF. And then, for some of these use cases, like streamlining literature review, I think there's a lot of promise if we think about refining these models to focus on bodies of text that we trust, like the peer-reviewed literature. But what I'm most excited about, and what Aaron also alluded to, is the opportunity for task automation and the potential to reduce, clerical work for physicians. So let's take a quick look at an example of that. Perfect. Okay, so this is an example of a MyChart message that was shared with me by a GI colleague. So the patient's concerned about fatty changes in her liver and hyperlipidemia that's related to a drug she's on called Xeljanz. And she'd also like a TB test for work. So I just put this de-identified information into ChatGPT, and you can show the next slide. And here's the response that it generated. So you can see it reads like a thoughtful response. So it lets her know that we ordered a lipid panel and a TB test as she requested. It asks her to schedule a follow-up appointment and discuss the results and potential alternative treatments. And then it makes lifestyle suggestions. And then finally, it writes with a compassionate voice, which I think patients really appreciate. So, imagine you open up your in-basket and all of your replies are pre-drafted by an algorithm that read the patient's chart when it's drafting the response. And so now your job in replying is really to edit for accuracy, which could be a total game changer in terms of reducing in-basket burden and clerical work for physicians. Okay, so what are the risks of these large language models? So the CEO of the company himself, Sam Altman, he's been very transparent about his concerns. He tweets about it a lot. And he said, ChatGPT is incredibly limited, but good enough at some things to create a misleading impression of greatness. So, one of the problems that's quite obvious is these models are trained on the internet, and the internet's obviously biased, which can lead to bias in the models. But one of the phenomenons that we see is something called hallucination, which can be quite troubling. So I'm going to show you an example of that. Okay, so hallucination in large language models means exactly what it sounds like. So the model essentially fabricates information while remaining quite persuasive. And this happens because these models are actually trained to provide a response that sounds plausible, even if any physician would know this request is totally inappropriate. So in this example, I asked it to request authorization for an anticoagulant, apixaban, to treat insomnia. And the request is obviously totally inappropriate, but the AI program attempts to justify it by including statements that are entirely, incorrect, including nonsense about recent studies in the literature looking at this. So I think this illustrates why these tools, they could be great drafting tools right now, but they're nowhere near replacing physicians. Next slide. Okay, so what's next at UCSF? So we're looking at piloting a tool called DAX, or Dragon Ambient Experience. It's made by Nuance. And the idea is that you have this tool listening to your entire clinical appointment. And it'll generate a note. At this time, those notes are actually reviewed for accuracy by a human at the company. And then effectively, it functions as an AI replacement for a scribe. So there are some challenges with this. It's in relative infancy. There can be very variable performance based on your specialty. There's a pretty substantial ramp up period as the tool learns. Currently, it's actually the same. It's about the same cost as human scribes, which, as you know, can be tremendously expensive. But I'm optimistic because Nuance is actually now a part of Microsoft, who has the exclusive license for GPT-3. And so I think, these tools are probably going to get dramatically better over the next couple of years, and hopefully the costs will come down too. So I'll turn it over to Dan.
Great. Thank you, Sarah.
Yeah, thanks, Sarah. So let me just say at the outset, for those of you in the audience who know the four of us to any degree, you should be able to identify me as the true outsider here. I am, an armchair techie at best. And the main reason that I'm with this esteemed group is that Aaron Neinstein, a couple of months ago, when he brought up this topic to us, I think he suggested that there's a bit of a futurist in me, because I like to think about the future. But that's not really true either. I predicted that Segway and Google Glass was going to be universal by now. So there you go. But my comments are really to focus just for a few minutes on the potential application of ChatGPT and these types of new developments in medical education. And I think you've already heard a theme weaving through this. For those of you who have not tried ChatGPT or have just heard about it from a distance, I think my conclusion is that we have, at this point, is that we now have a new incredible expertise, even a genius, in language processing, to provide language and to have it reflected back in different styles. But we're very much have a novice when it comes to knowledge processing, and that's the problem I think that we're going to have to contend with, and I believe actually solve. So, just as an example, I'm focusing on education, but I did want to make a comment about the opportunities here in the world of research. Just one small example. Many of us in research develop 2-3 page summaries of the work that we're doing for various audiences, and sometimes have to then reduce it down to a 1-paragraph description in lay language or for a scientific consumption. And I did this with ChatGPT the other day. Took one of my 2-page summaries on an epilepsy genetics project that is detailed and is meant for program officers at NIH, and asked GPT to create a 250-word summary of the project in lay language, and it did it beautifully. Very accurate, because it was taking the information that was perfectly accurate on the 2-pager and reducing it to a paragraph. So that's one very clear example, I think, of the way this is going to be enormously helpful to our workload with our writing. When it comes to medical education, I was thinking primarily at the undergraduate medical education level as a start. And I actually asked ChatGPT to give me an overview of the way it might be able to contribute to medical education. And it included things I think that made a lot of sense, providing information on a wide range of topics, supporting self-directed learning so that students have yet another resource to go to, improving knowledge retention by engaging in an interactive back and forth conversationally, encouraging active learning, and then supplementing traditional education methods. And it also included acting as a tutor. So I thought about that for a while and decided that I would test ChatGPT on one particular question that comes up all the time when we're teaching neuroscience to our first and second year medical students, and we're delving into clinical neuroanatomy. And the concept that is very difficult to grasp, and it takes a number of iterations and conversations to figure it out, and that is understanding the difference between facial weakness from an upper motor neuron versus a lower motor neuron lesion. And there's some somewhat complicated anatomy involved. And I won't actually quiz my colleagues here on rounds as to whether they actually know that explanation now, many years after taking neuroscience. But I just know that this is a concept that we always go through with our students. So I asked ChatGPT.
Something crosses over somewhere. I remember that.
Yeah, bless you. That's
Okay.
that. Yes. Well said as an intro. Thank you. Perfect. Thank you, Bob. So I had a conversation with ChatGPT on this, and it did reasonably well as a start, but clearly some mistakes factually. So I can tell you that for the students who are looking for explanations that go well beyond just a conversation and general information, we've got a lot of work to do to help it learn. And actually, I tried to assist it. So I then, after its initial description, came up with the overall concept. It had one clear factual mistake, which is a lesion down in the spinal cord can cause facial weakness. That doesn't happen. So I responded by pointing out that I'm a professor of neurology at UCSF and I teach neuroscience. And then I explained the problem with pointing out the spinal cord. And it came back and apologized for the mistake and updated its explanation and did a better job. Then I did something rather nefarious. I actually then claimed to, actually I was wrong in what I had originally told it. In fact, the spinal cord does innervate the facial nerve, and it came back and again apologized for the mistake. So I bring this up just to again emphasize the point that I made at the outset, and I'm really interested in hearing from my colleagues about how we're going to navigate this in the future, which is we have an incredible resource when it comes to language processing that certainly I've never seen in to date, that I'm certain is going to really impact our lives in a major way over the short term. But how are we going to deal with helping it become an expert, if not genius, in knowledge processing? So with that, I'll turn it over to Atul.
Great. Thank you, Dan.
Great. Thanks, Dan, and thanks for having me here. I'll start my slides. I have a bazillion conflicts of interest, not even worth listening. All right, so I'm going to present a few other things that no one's mentioned yet. I get excited about ChatGPT because of articles like this, where it's able to pass the USMLE now. Those of you in the audience know that we take tests like this to get licensed in the United States. And it's one thing to have a ChatGPT pass the USMLE, but it also passes the bar, and it also takes tests in to get a MBA. So it's the same, knowledge base, let's say, coded in a language model that's able to do all of these things. And so clearly, very exciting time for us in medicine. It's an exciting time for everyone. Today's news is that ChatGPT reached 100 million users already in January. To give you a perspective, TikTok needed 9 months to get to 100 million users. Instagram took 2 years. Gmail and Twitter took 5 years, and Netflix took 10 years to get to 100 million users. And ChatGPT took just 2 months. So you can tell why everyone's excited about this. Already 13 million users a day. There's obviously a lot of money in this. So Google now in kind of competition invested 300 million into another San Francisco company, Anthropic. But then yesterday, Google demoed their response. And the first output, as some of you saw, was incorrect about what the James Webb Telescope had discovered. And the shares dropped $100 billion with a failed demo. Unbelievable how much money is going into this. Of course, Microsoft is investing 10 billion now more into OpenAI. But I don't know about you, but when I think about Microsoft and AI, I always remember this old friend from several decades ago. I'm probably dating myself to show Clippy here, but again, all due respect to my friends at Microsoft and colleagues, but we'll see how Microsoft uses this in Office and all these tools. And then this meme has surfaced that as everything we're talking about is GPT-3 and GPT-4 is under construction right now. And you could just see how much larger that is. Maybe this will be out this summer, even perhaps later this year. So an exploding time. Certainly, we don't have medical students that can change how much they learn or grow that many neurons in the course of a 4-year medical education, right? So you can get the idea here. Now, UCSF is not behind, right? We've had a lot of partnerships. Many of the folks who have already been on this Zoom have had these partnerships, execute on these partnerships with companies, because we need to work with companies in a safe, responsible way to learn how to do this. Everything from GE's X-ray machines now having the built-in ways to tell if there's a pneumothorax, all the way out to trying to predict the future for patients with Google and others. But we got to do this in safe, responsible ways. I think we've learned how to do that. And we have lots of faculty at UCSF who've been pushing the edge in AI as well. And to give just a small smattering of some of the papers here, whether it's work in predicting the future, whether it's in orthopedics, with Tom Peterson, Rima Arnaud talking about congenital heart disease and cardiology, Jeff Tyson working with folks at Janssen, and many others on EKG reading and pulmonary hypertension. And of course, a huge effort in radiology and imaging sciences with Sharmila Majumdar running the Center for Intelligent Imaging. So we're not behind, but we certainly have a lot of running to do since we're all excited about what we can do with ChatGPT. Now, because most of the audience here is from UCSF, just putting in a plug for Information Commons, you too can get to this data and learn how to build AI tools, right? We have staff and researchers here to help you. Just go to informationcommons.ucsf.edu to get to all the clinical data, most notably the text, right? Because all of what we've been talking about is exciting because of the text. We know there's images, there's a lot of AI going on there, but boy, it's exciting to see what's happening with text. And you as a UCSF researcher can get to 120 million legally de-identified text notes now to start to parse, to do chart reviews, but of course to start to train for machine learning and concept identification and all the rest. Now, because we have all these de-identified notes that are legally de-identified, we can start to see what would ChatGPT do with some of these notes. And so a postdoc in my lab, Madhumita Sushil, superstar in natural language processing, has been trying some of this. Now, on the left there is an actual note, fully de-identified. If you see any dates left in there, they're artificial dates, but nonetheless, I try to block out the dates. And this is a patient, this is a progress note with someone seen at UCSF for breast cancer. And it's a long note, as you can guess, most of our notes are. And one simple statement at the bottom, give me all the cancer biomarkers, right? And right away, ChatGPT, with just off the shelf, knows ER, PR, it actually explains ER is estrogen receptor, PR is progesterone receptor. That doesn't appear in the note, by the way. And amazingly, at the bottom, it figured out MP is a biomarker called MammaPrint. Now, Madhumita showed this note to two of our curators who read these notes, one of whom is an oncology fellow, and missed that MP is actually MammaPrint. So ChatGPT off the shelf can already figure out that's probably MammaPrint in this context. You can see MP high risk, it's not explained anywhere else. Off the shelf, it notes that's a biomarker. Can you give that to me in table form? Immediately figure out you probably want the left breast and the right breast as the columns. And so that's sorted out. But you see MammaPrint is missing here, right? And of course, we're cherry picking some of these examples here. In fact, can you just keep all the radiology and pathology, conduct with all the test sites and dates and results, and boom, here's your table. I don't know about you, but we used to have medical students summarize this stuff when we had 100-page charts. And boy, you can start to imagine the future that ChatGPT, even off the shelf, is able to figure this out for a patient. What are the treatment options for HER2-positive breast cancer? Well, off the shelf, it knows the different categories of therapies, gives some examples. But before 2013, what were the treatment strategies? You can see it already knows when these drugs were approved and how treatment would have been different. So are we that far away from asking these kinds of questions? How should this patient be treated if we are trying to avoid a specific side effect? How would you take care of this patient if you were Bob Wachter, right? The same way how Bob said, give me a review of Grand Rounds as a movie review, give me an assessment and plan if I were Bob Wachter, right? You can imagine that could be future. How would I take care of this patient if I were Memorial Sloan Kettering? How would I have to take care of this patient if I were United Health paying for some of this, right? And you can start to think about where these questions are going. It's not too hard to guess they're going to go in this direction here. Now, the FDA is all over this. We've had this concept of AI machine learning as software as a medical device. This cover comes from a report hardly 4 or 5 years ago. But even today, more than 500 AI and machine learning tools and methods have been approved by the FDA, 150 already just in radiology. And these links are just constantly changing every single week here. Very active field. And you start to get the glimmer that if we're not inventing some of these things, we're going to have to buy some of them at some point. So we should be on the innovation side as an academic medical center. It's a complicated environment, though. As we know, there are biases in the data. There's biases in how we give care. Thus, there are going to be biases in the medical algorithms unless we know what to do to fix those and how to correct them. Now, there's an aspect of fixing the algorithms, but there's a better and bigger problem fixing the medical system, right? But bias in GPT-3, battle for ethics and how to actually define ethics and transparency. Over last summer, the US Health and Human Services announced stronger rules for non-discrimination in algorithms. Our Attorney General in California put out a request to 30 different hospitals asking, well, how do we steward these algorithms? FDA then came back in September and said tools to look at sepsis, which is how Aaron started, should be regulated as devices. A week later, Epic said, hold on a second, don't use our algorithm anymore. We got to overhaul that. And then the White House comes out with an AI Bill of Rights. All of this is just in the last 6 months here, right? So it's an extremely active time here. In the last couple seconds, I'm going to end with some philosophy. Maybe we can use this to get into the discussion here. We are at an academic medical center. We're going to believe we're one of the best academic medical centers. And so if you think about our education role at academic medical centers, we have always had this role of training the next generation of practitioners, right? Nursing students, medical students, dental students. We create and evolve a curricula to train that next generation. We execute on that curricula, and then we evaluate how our performance is. And we can't do this ourselves, right? So we work with partners to help teach our students, publishers, case-based materials, online tools. And then we make sure our next generation passes their regulatory hurdles, whether it's USMLE, nursing exams, nursing, dental credentialing, licensing. So then why aren't we, as academic medical centers, as driven when the next generation is going to be computational? Why are we just handing this off to companies? And I believe it should be our role as an academic medical center to teach this next generation the same way we teach humans in the next generation, right? We shouldn't be just handing this off to companies right now. Our responsibility has to go into teaching ChatGPT-10 or whatever about how to practice medicine. We got to research the best curricula to use to teach these computers. We got to evaluate how well we're doing. We need to partner with companies to do this. We're not going to be able to do all this ourselves, but we also have to help these new learners overcome regulatory barriers like the FDA and the rest. We shouldn't just hand this responsibility off to companies, whether it's OpenAI or Microsoft or Google. We got to work with them, but it's our responsibility too. So I'm going to end with that and see where the discussion takes us here.
Great. Thank you. Thank you all. Really interesting, thought-provoking talks. It's a mind-blowing topic. Let's start with where you ended, Atul, and start with the educational mandate in this environment. People have been saying this for years, but I think when you use ChatGPT, it sort of it puts that question on steroids. How important is it going to be for people to know stuff? When you talk about changing the curriculum, I think you were talking about learning to do, to deal with the companies and expand the frontiers of knowledge about AI, but just the foundational curriculum of learning to interpret, a blood test or whatever. Does that need go away when you have tools that are this powerful that are at your fingertips? Maybe you could start with that, and then maybe Dan.
Yeah, I'll go quickly first. So for curricula, it's certainly we're going to change our curricula for all of our students, but also I'm imagining curricula to teach the AI. It turns out if you teach the AI in different case orders, it learns different strategies. But certainly, I think people have been saying, worried about students for a long time, whether it's pocket nomograms and Google, right? I mean, you have doctors using these tools too, and so this is the next generation of those. It goes back to calculators in our pockets. So without a doubt, we're going to offload some thinking into these. A long way to go, as some of the examples have shown, but I think we're going to be using these more and more. Dan, I'll turn it over to you to try to.
Yeah, and I agree. This is hardly a new question. And in fact, this thing, 2006, universal, ubiquitous, and instantaneous access to information, not knowledge, but information. Mm-hmm. Many of us have been saying this is beginning the era where people, including healthcare providers, don't need to be carrying around, minutia. What was someone once called biodegradable facts, right? So I am hoping for the time when the boards, for example, finally gets rid of any of the questions that ask someone to remember the name of an enzyme or, a gene mutation that's the cause of disease. I don't see any reason for that at all. The challenge, again, that has been around for decades is how do we understand the conceptual learning that underlies health and disease? And one example is, we all know what action potential means. We learned about it back in our, in medical school. It applies to the brain, it applies to the heart, and many other things. What do you need to know in order to have the concept of what, electrical propagation down the heart or the nerve actually means? And that's where I get a little bit, I still don't know where we're going, because you need to put in a certain amount of detail into your mind for a period of time in order to then come out with the longer term, oftentimes lifelong concept. And so I'm hopeful that a knowledgeable processor is actually going to help the individual student develop that conceptual basis in a much, much more effective way, and actually open up more cerebral cortex for conceptual learning rather than, again, these factoids.
Great. Let me stick with you for 1 second, Dan, and then we'll get to Sarah and Aaron and talk a little about some of the clinical implications. Tell me a bit, what's your thinking? You were the chief academic officer at UCSF for a long time, so this probably would have landed on your plate. What does plagiarism mean in the era of ChatGPT? What does authorship mean in the era of ChatGPT?
Yeah, it's not something I've thought about when it comes to this new era until very recently. And I think we've yet to determine what the ground rules are going to be. I mean, I would think that disclosure as to the reliance on where the sources of information have come from will be necessary. So I'd like to think that would be part of, say, the research sociology. On the other hand, what about providing letters of recommendation or letters of assessment for promotions? Do we need to declare that? I did this the other day for a student just to try it out, and took a bio and asked for a letter of recommendation, and Chat gave me a very, very good starting point for a draft. Is there anything wrong with me just simply using that and modifying it as I wish without declaring that was the source? I'd be interested in everybody's response to that.
That's probably no worse and probably even better than what often happens, which is the student writes, or the recommendee writes a draft of it and you modify it from there.
That's right.
Interesting. Atul?
Yeah, just quick answer. I think the journal editors and publishers are starting to come out with their responses for ChatGPT. I think we got two extremes. Science, I think, says no ChatGPT at all. JAMA says, I think you can use it, but you got to acknowledge it. There are folks who say, they might use Grammarly already to fix grammar. Why is this any different? So I think the editors are starting to put out their policies for sure. We'll see more of those.
Yeah, exactly. All right, let's turn to some of the clinical implications. Aaron, you said something interesting. A lot of what's going to happen here, we hope, is that this will restore the things we love doing. Do patients really care what we love doing? And isn't really, at the end of the day, if this does what patients need, as well as, but cheaper than us, then it will win. So, sort of reflect a little bit about on, I'm sure we'll get into the role of physicians and role of clinicians in general. But, are you hopeful that it will make the lives of doctors better, but also the lives of patients better? And how do you think through that question?
Yeah, I'll tell you, I had the same when the first closed loop insulin delivery systems came out. I had the same fear. There were those first couple of years. This is about 4 or 5 years ago now. I thought, well, maybe my type 1 diabetes practice is over because people are going to have the machine manage their insulin delivery. They don't really need my expertise anymore, and that hasn't happened. I think my experience is that it has allowed what people really want from us is not the computer or the computational because that can come from elsewhere. They want our curiosity, they want our guidance, they want our healing conversations, they want to engage with us, and it has opened up my ability to spend time doing that with people, and taken the pressure off of the computational work and all of the memorization of things. And so, yeah, so my personal experience is that it has augmented my ability to be an effective physician and a healer. I think in general, you're right. People don't care what doctors want to do, but I do think, you look around primary care right now, patients are not happy, doctors are not happy, people are burning out, they're spending a lot of their time on administration, bureaucracy, paperwork. And so I think, at least in the early days, taking that work out of the system and giving our doctors, our nurses, more time to spend with patients feels like it's going to be a really net positive.
Great. Sarah, any comment you want to make on that?
Yeah, I think, just to echo Aaron, I think everyone will be happier if doctors are spending less time doing tedious clerical work. I don't think anyone wants their doctor doing that work. I think we have to be careful, as we start thinking about implementing these as drafting tools, where I do think there's a lot of promise. Other industries have started doing this, like CNET, for example, writes a lot of their articles with this technology now, and everything is supposed to be reviewed by a person, but they're finding errors in these articles that clearly a human didn't make, a human author wouldn't have made, that the technology makes it, and we're not catching, or they're not catching it. So we just have to be careful, I think, as we start rolling these things out, that we don't put too much trust in them, that we don't get sloppy. But I think overall it's going to reduce a lot of clerical work, and I think everyone will benefit.
Sarah, you mentioned that one of the things we've got to figure out is how to integrate them into the health system. I'm sort of interested in the path toward that. You mentioned, ChatGPT draws its source of brilliance from the internet, but not from Epic, not from charts. So where is it going? So what's the point of integration? Do we have to buy it? Do we buy a third-party tool? Does Epic buy a piece of ChatGPT? Does Microsoft buy Epic? How does this all come together? And then what is the experience at the end of the day for the end user, either the doctor or the patient? Because I think we have as many patients on Epic today as we have clinicians.
Yeah. Gosh, this could go in a couple of different directions. I think, as a tool suggested, we could be co-developing this with companies like Microsoft, which I think is probably the quickest path to getting this implemented. These models, so there are all these unsupervised models that are trained on the corpus of the internet, but then you can do kind of supervised training on top of them, or you can add additional information to them. So these models could kind of be like additionally trained to also read the patient's chart when it's responding, and also read my history of responding to patients, so it knows how I like to speak and my tone and that type of thing, and then incorporate it into it. In terms of, I think the scalable solution is that a company like Epic collaborates with a company like Microsoft, but I don't know if that's the fastest path to implementation.
Mm-hmm. Any of you, the AI has been hyped as being sort of around the corner for 30 years in healthcare, and basically flamed out. People talk about the AI winter, when after the original tools that were going to replace doctors' diagnostic skills, it didn't go anywhere. They gave crazy answers. The field kind of died. Was that simply a problem that the tools weren't good enough, and now this tool is good enough, so it is going to take over? Or was it a problem? I think Aaron was implying that some of the problem was asking the wrong questions. The integration wasn't very good. So is it just a matter now that we have a really spiffy tool, it's going to win the day, or it's a harder problem than that? I don't know. Maybe Aaron starting a tool. Maybe.
Yeah, I think it's a little bit of both. I think this is categorically different. I think, the first time I sat down to use GPT, and others have probably had this experience, and Dan, held up his iPhone, I had a moment of the world has changed and will never be the same after this moment as it was before. And so I think there is something about this, where the technology has gotten to and its capability. And as a tool said, GPT-4 is around the corner and is supposed to be an order of magnitude more impressive. I think there's something about the technology here that is categorically different. And in particular, because it's so general, I think the problem I was articulating earlier around solving specific problems, you need to spend a lot of effort building the right algorithm to answer the right question, putting in the right training data, designing the right workflow. I think as Sarah showed here, that may not need to happen here. I mean, we can pretty easily imagine the experience of opening my InBasket, tonight in the future world, and sitting down and having responses trained on my last 10 years of InBasket replies, and reading that patient's chart, teeing up a draft of a reply for me, letting me edit it, and sending it off. I think this is categorically different.
Sarah, and then Atul.
Yeah, I totally agree with Aaron. I do think that we will still have use cases where, more quote traditional AI is applicable. For example, my team's building models to support our command center for patient flow. And, GPT-3 is not designed to predict which bed will become available in the hospital next. And so there will still be other applications for the, that more traditional AI.
Why, when you say GPT is not designed, I guess you look at some things that it does. It wasn't designed to do my grand round spiel in the form of a movie review. It wasn't designed to do anything really. In a way, it was designed to so why would that not be a solution for what seems like a relatively straightforward algorithmic problem? Tell me which bed is going to become available and which patient should go in it.
Yeah, well, so GPT-3 is, understanding the meaning of what you're saying and predicting the most plausible response to what you're saying. And that is different than, that's basically like, let me describe an apple to you, and then transformer models like GPT-3 can then draw the apple. It's not traditional AI is more about, let's separate. Can you build a model that'll tell me the difference between apples and oranges? And so I think there's different ways that we need to predict changes in data that are not necessarily, GPT-3 is not necessarily applicable to that.
I think Atul was next, and then Dan.
Yeah, so it's definitely a different time. And the hardware is better, no doubt. We got chips and stuff that are very AI specific, but it's because we have more data, right? So if you think about the old AI winter, the strategies were very different, right? Those were rule-based systems where we didn't have a lot of data at the time. So experts would come and ask other experts, what do you do if you see this? What do you do if you see that? And it takes forever to get experts to tell you that and then put that into software code. And now we don't have to ask anyone. We just see, what did you do, right? It's in the electronic health record, right? Why? It's amazing that we have 120 million notes at UCSF, but 11 years ago, how many did we have? I mean, so we installed Epic 11 years ago, right? So, and the rest of the world is catching on to that too. So much more data is captured that machine learning, learning from data instead of rules, totally is usable in medicine now. It's absolutely different time.
Hearing you say, it's just learning from what did you do. Of course, it raises the question: what if what you've done is wrong, or biased? Obviously,
well, on average, we do the right thing, and I'm going to argue at UCSF we probably do the best thing. Let's say, right?
Great.
And so,
Great.
On average, it's going to learn something from us if we choose to teach it.
Terrific, Dan.
Yeah, so this is a question as an outsider to the real experts here, and that is I'm very concerned about the misinformation, just the massive amount of things that it can get wrong, and I've been wondering, Wikipedia, when it came along, it was kind of a knowledge management system, right? And it had all kinds of problems starting out, but it's leveled out in terms of self-correction and knowing when information is likely correct versus not. What's your prediction in terms of the time scale, or the capability and the time scale for GPT to evolve into a knowledge management system?
And how much of Wikipedia's self-correction was this sort of less scalable humans intervening and looking and saying, this is craziness, I'm not going to allow it to go through? Anybody know kind of that history of Wikipedia in terms of how it did it and whether that's relevant to what's going to happen here?
Well,
I think go ahead.
Go ahead, Sarah.
I was going to say, I can't speak to Wikipedia, but I can tell you. So, I mean, I think people, the data suggests GPT-3 or ChatGPT hallucinates like 20% of the time. And since it's been released, there's already been additional AI release, like a company called Gada AI that I think catches 90 to 95% of the errors. It's AI designed to catch the errors in ChatGPT. And so I think as we see, I think tools like this are just going to be rapidly released, and I think it's going to get good fast.
But that requires iteration, that Dan told it you made an error, and it was nice enough to apologize. And then Dan told it you were wrong. You're right about your error, and it believed that, so it's kind of gullible. But so the autocorrection loop, the sort of iterativeness, I mean, Google got better over time. I remember when I visited Google's one of the early times and talked to the person who designed search, and he said, you know, when you search and you click on the third link, we know we screwed up. If you go to page 2, it's like code blue. We like go, something's terribly wrong, and we're constantly optimizing to be sure we got it right. What's that feedback loop in ChatGPT? How do they know they didn't get it right and they gave you BS?
Right now, there's a thumbs up, thumbs down. There are also teams looking at these transcripts, right? I mean, internally, not necessarily specifically for medicine and all, but I think they've captured enough of many different industries' imagination that many industries want to participate with them now, right? Yeah. So I think I can imagine if UCSF someday wanted to partner, I think we can imagine safely, responsibly partnering with some data, right? Again, de-identified HIPAAs, 25 years old, but also putting in some evaluators in there to see and to try things in pilots here. Yeah. If we don't do it, someone else will do it, right?
Makes sense. A bunch of questions. The ethics issue comes up all the time. So anybody want to address this issue? You know, sort of maybe focus on the issue of bias, that it's going to replicate what has been done in the past. If what's done in the past is biased, it will now give it the imprimatur of this brilliant magic machine. So how do we think about that, and how do we protect ourselves against that?
I'll go first, and I'm going to say a pithy statement, Bob, which is not going to solve any of these real challenges here, right? But I'm really glad that the diversity of the world is in California, treated by the University of California, right? So if we use our data to train some of this and participate, I can hope, right? We'd have to evaluate that. I can hope that these models might be a little bit more fair to the subpopulations that we all need to respect and treat. But that means also getting data and participation from hospital systems that might be behind, who are just putting in Epic now, or might be thinking about putting in some electronic health record system 2 or 3 years from now. Those populations that are going to be underserved in this new revolution, unless we get that kind of data in there too. So I think we have a new responsibility there beyond just treating those patients to make sure they're part of these solutions moving forward.
Yeah, great. Thank you, Sarah. And we need to finish up in a minute.
I was just going to say, I think we're going to, while we have less influence, on the entirety of the tool, as we think about use case implementation of healthcare, we are putting in systems to monitor bias in these tools long term when we implement in the health system. And so I think it's going to have to be use case specific as to the bias we're looking for in these given tools.
All right, great. We need to finish up. Last question. 10 is you are ecstatically excited. This is the greatest thing you've ever seen. 1 is you're really scared out of your wits about dystopia. Where are you on ChatGPT today? Aaron?
I am a 1 and a 10. I think this is both the most exciting thing and terrifying at the same time.
Great. Sarah?
I totally echo Aaron. I think that, Sam Altman was asked this question, and he was like, the worst case is lights out for all of us, the world ends. So hopefully that doesn't happen. I mean, we can use it for really good things.
Yeah. Aaron, Atul?
I'm going to say 100 because I feel like we're in Silicon Valley. We know all of these companies. We know these folks, and we have our data. I want to be part of the solutions here. Safe, responsible solutions. I think we can do this at UCSF.
I think the algorithm would have to adjust for your usual optimism and sort of can do. That's great. Dan, last word.
I'm not smart enough to know, so I'm just going to leave it to my colleagues.
All righty. Thank you all. Really, probably about the most interesting topic in the world, and I thought you handled it incredibly well. And obviously, there's much more we can and we'll be talking about. We'll do it again. But thanks for tuning in, and we'll see you back here next week. And let's make this work for us.